Hello, everyone. We are live from SADS, and this is SADS Live 171. Great to get to be with you. I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic and director of Mayo Clinic.
Sorry, guys, we lost Mike for a quick second. We'll get him back on. Oh, there he is. Just 1 second. I'll try to entertain while you're gone, Mike. I'm not as good as you.
Yeah. Well, that was interesting. Sorry about that. Here we go. Let's do take two. I clicked the wrong button when I was trying to silence all those pings that were coming in from my email chain. Sorry about that. Live from SADS, and we are live for episode 171. So as I was saying, I'm still Mike Ackerman, and besides being a genetic cardiologist at Mayo Clinic, I'm here on behalf of the Sudden Arrhythmia Death Syndrome Foundation, the SADS Foundation, your foundation for all things related to your genetic heart rhythm condition. And we hope you feel like this is your home and you're thankful for us at the SADS Foundation, where our goal is for you to live and thrive. 2 days from now, we celebrate Thanksgiving here in the United States. For those who are in places around the globe that are not, we're still thankful for you and for all that you mean to us as part of the SADS family. But this is a moment where we can pause and reflect and give thanksgiving. In fact, I was just reading today how an ungrateful spirit is the enemy that we need to viciously counterattack with an attitude of gratitude. And I find that true. I mean, one of the ways to dispel anxiety in a hurry is to count your blessings. And I'm grateful for many, many things. And on this Thanksgiving week, I am particularly grateful for each of you in our SADS family. So if you have an expression of gratitude that you would like me to share, put it on the side. But until then, I will start at the top, as I always do, and pick your questions. I do not skip, no matter how hard they are. And your questions are typically amazing, almost always. So this is somebody new, at least I don't recognize your name, Malgarazata. I love that name, and is asking, can a negative, remember, I cannot give direct patient family advice. I take your question and you do my best to comment and illustrate what are some of the key issues surrounding that questions, what are some insights based upon that question. So back to Malgarazata. Can a negative EP study reliably indicate low risk of dangerous arrhythmias? Is bigeminy dangerous when the QT interval is prolonged? Really good questions. And so the short answer, as many answers often are, is it depends. So an EP study, and that is a study where our EP, our heart rhythm specialists, our electricians, they put catheters inside a neck vessel, inside the groin vessels, and they bring those catheters to the inside of the heart and electrically map the inside of the heart, and will sometimes try to see, is it easy or hard to induce a danger rhythm, a ventricular arrhythmia. And that's part of what's called the EP study. Now, in general, we never, and you can never say never, but we almost never do an EP study for long QT, almost never do an EP study for CPVT. We do EP studies from time to time for Brugada syndrome and for ARVC. Now, like with any study, negative never means zero risk. So a negative EP study in the case of Brugada, for example, where it did not induce the danger rhythm, so they were negative, and it was a negative EP study, that forecasts about a 0.5% chance per year of an event, so very low risk. Whereas if it was positive and it easily induced the Brugada danger rhythm, then that positive EP study would predict a chance of around 1.5 to 2% chance. So it's not as if positive means danger around the corner tomorrow and negative means never, but it certainly means and fits with low risk. As to the second part, unrelated, is bigeminy, and that is a characteristic pattern where there's a skipped beat from the bottom chamber called a PVC occurring every other beat. That's where the word bigeminy comes from. And is that dangerous when the QT interval is prolonged? Well, first off, that pattern is characteristic in CPVT, but seldom seen in long QT syndrome or when the QT interval is prolonged. So I would be putting on my detective hat and wondering, do I fully understand what's going on? Because why am I seeing both QT prolongation and PVCs in bigeminy? So I'd need to do some thinking there and do some detective work to figure out why are both coexisting. And do I have patients who have both long QT syndrome and CPVT? I do, but that's really, really rare. Helen gets question number 2 on this Thanksgiving week. Can a sudden increase in heart rate, for example, when standing up, cause the QT to lag behind and not shorten fast enough? And if a PVC happens at that moment, could this trigger SADS? Great questions to start. In general, no. So very unlikely for sitting to suddenly standing, even with that orthostatic change in heart rate, cause and trigger and upset the long QT heart. That is just almost never a setting for a long QT episode. Now, can you faint going from sitting to standing, or almost faint going from sitting to standing where you get lightheaded and dizzy? Answer is yes. And that most often is non-cardiac near fainting, or if you did faint, non-cardiac fainting. So could it happen in LQT1, for example, when you have a brisk heart rate response and the QT did not adapt and shorten like it normally should? Could that paradoxically lengthen the QT to set up a window of vulnerability for an ill-timed PVC to catch the heart off guard right at that moment? Theoretically, yes. Practically, it seldom is a setting for a long QT episode. And we have a thank you and a happy Thanksgiving to you too. And you are LQT1 gene positive, so you own an LQT1 causative marker, but your QTC is borderline and you've never had a symptom. That's great. And I can't tolerate beta blockers. When would I consider denervation? I love the question. As you know, left cardiac sympathetic denervation, or LCSD, is a minimally invasive surgical procedure that we do more of at Mayo Clinic than any program in the world. Advertisement, I guess, but it's true. I like it a lot. The surgery is exquisitely protective, not curative, effective for LQT1 more than every other genotype. So it works best. So when I have an LQT1 patient who is not tolerating their beta blocker, which is the number one therapy right now, then I ask myself the question, where am I in their risk assessment? Do I think they need therapy? If the answer is yes, I think they need prophylactic therapy and they're not tolerating their beta blocker, then that's a perfect indication to shift over to denervation one-time therapy. On the other hand, if I was debating between trying the beta blockers versus doing nothing, what we've called intentional non-therapy, or INT, although it's not truly non-therapy because we talk about all of the QT preventative measures and ongoing monitoring. So we are doing something, But when we're choosing between that, then I will have patients who are hating their beta blocker, and we will sometimes shift them to preventative measures only because I was on the fence and we together were on the fence and we thought their risk was super low. And we currently follow about 200 patients where we together have chosen not to treat. Now, either that's because we never started the treatment of beta blocker, or we tried the beta blocker and we tipped the balance towards everyday side effects. Thanks a lot. Now I feel lousy. And then we're working our way back to coming off of it. Now, having said that, thanks a lot. You've made me feel lousy every day. That is not universal with beta blocker therapy. Remember, we have lots and lots of patients who are living and thriving on their beta blocker. So just because you're on a beta blocker, that doesn't mean you will be or you are the proverbial beta blocker zombie. For many patients, at least in our program, 2/3 to 3/4, their quality of life remains very high, living and thriving on their beta blocker. And thanks, Christy. I appreciate that note. Merrick is asking, hi, I often record ECGs at home with my smartwatch, and I also calculate the QT, but I'm still not sure which reading I should trust. At a heart rate around 90, a 30-second ECG sometimes shows a QTC of 470 to 480 and 500. How should I interpret these differences? I love the question, Merrick. I would say for the most part, stop measuring it. And the reason I say that is we have data, true data to guide us as to what a person's QTC means when they come in and they get a 12-lead ECG at 8 in the morning before seeing a long QT specialist. We are starting to have data what happens to the QTC in 24 hours when you do a Holter. And admittedly, I don't think that data is as good. We have no idea what happens to the QTC throughout a life wearing the smartwatch. What are the oscillations in the QTCs? In other words, a QTC in your annual ECG randomly that is persistently catching your QTC at 480, 490, 500 means way more to me than a smartwatch QTC that happened to say 490 at 3:31 p.m. Now, will we learn what new information surveillance monitoring will do? Yeah, in time, but for the most part, I think it's mostly increasing anxiety and worry, not increasing confidence and peace. Now, where do I like the home monitoring, the home QTC? Whether it's the smartwatch or a live core, full disclosure, we help develop some QTC knowledge in the cardiomobile device and the like. Where do I like that home monitor? I like it a lot if there's been a health disruption and they're really sick and under the weather and they're wondering, are they dehydrated? Is their potassium low? Is my QT reacting? Or they need to be on a medicine. And oh, by the way, that medicine's on the QT drug hit list. Is it safe to take? Yes, we're going to start it. Maybe we can do some new drug QT monitoring to see if I'm a QT reactor and get an early at home signal indicator. I like it a lot in that setting because now we're collecting baseline data and after intervention, starting my new anti-anxiety medicine, for example. And so I think there is a use case for home monitoring, but it's just like the person who's always putting their arm in a blood pressure cuff. Why are we doing that? So if you don't need to be doing that, I think instead of looking at your smartwatch, you should go out for a run and enjoy the sunshine. Thank you. And we at SADS are very delighted that you're with us. A reminder from the SADS Foundation, besides our gratitude, this is our last week of Family Health History Month, where we made it a point to know your family history, because that story, that history may be an important part of your story. So know your own story. Do you have a warning sign? Do you exhibit any of them? Sudden fainting and the like. But do you also know your history? Because the story in your family needs to do that detective work. What happened to that near drowning victim, that relative? Was that an unexplained near drowning, or was that an alcohol boating accident and the like? So know your family history. LaDonna, I love that name. We got great names joining us today. Is there any new research to solve prolonged QT without the use of pacemaker and defibrillator? Oh, yes, there is. In fact, I think the good news is the vast majority of patients with long QT syndrome do not need and should not receive an ICD. That is a refrain that I make our adult heart rhythm specialists, especially, and pediatric heart rhythm specialists occasionally repeat over and over again. There is, in general, an overzealous use of the ICD in these genetic heart rhythm conditions where they're getting them too quickly. Fear and anxiety is promoted too much, and the ICD put forward as the solution, as the cure all. Now, do I like the ICD? I love it. It's an incredible invention. It has saved lives. Do some of my patients need an ICD? Absolutely. Have some of my patients receive life-saving shocks? To be sure. But do I need that ICD routinely? No. In fact, in our program at Mayo Clinic, less than 20% of all of our patients have an ICD. And some of that 20%, I inherited the device, and we might be working our way towards removing it. So even already, we can get by. We don't need an ICD the majority of the time. And I think we'll be making more and more advances to make the ICD less and less. In fact, as you know, those families out there with CPVT know that we try very hard not to use an ICD in that entity. Beautiful work. We participated in it, led by my dear friend Arthur Wilda, not a randomized trial. But when we compared in families with CPVT, those sudden cardiac arrest survivors who got rescued, and we compared those who then were diagnosed with CPVT and then got an ICD, compared to those survivors who were then diagnosed with CPVT but were treated without an ICD, and compared what happened. Well, the short answer is no difference in survival. Survival was equally good in both groups. So those who got the ICD for the purpose of survival did not show any survival benefit. So in that setting, all they received were ICD-related complications because the other group survived just as much and didn't have to deal with any potential side effects. Now, having said that, do I have CPVT patients with an internal defibrillator? Absolutely. So everything is a careful deliberation of the risk-benefit balance, the pros and cons, and shared decision-making and a judgment call for that family. But when I pick an ICD and we proceed with one, people will ask and say, is this forever part of my life? And I always, my comment is, I never, ever view an ICD as forever. I view the ICD as the for now strategy, that for now, all things considered, it may be making the best sense, but we're going to be reassessing. And maybe when that battery comes due, we will have gotten sufficiently smarter between then and now so that we would not need the ICD for the next go around. So it might be the for now solution. It for sure is the uncommon solution in our program. And it is not a forever strategy. Love that question, LaDonna. Leaky from Instagram, joining us from that platform, is asking, is it dangerous for someone with LQTS type 2 to experience a lot of autism stimuli? So I think what we're getting at is, what if I have LQT2, which can be auditory triggered, and I'm dealing with concomitant autism or autism spectrum, and maybe part of the behavioral therapies for that autism is stimulations of a variety of sort. My view is that in a well-treated LQT2 patient, the auditory trigger is not completely disconnected, but it is very well insulated. Meaning, yes, an auditory trigger, a startle, might be how a long QT2 family comes to discovery, just like a near drowning might be how an LQT1 family comes to discovery. But after discovery, risk stratification, and treatment, and tailoring of therapy, do I have LQT1 swimmers do it again in the water? Very rare. Do I have the alarm clock LQT2 person, once treated, do it again during their alarm clock? Alarm clock, very rare. So I would be freeing the behavioral specialist, if I was dealing with a patient with concomitant autism, to do their thing, to do their therapies, if I think I have treated well their LQT2. Anna is sharing that she's very grateful, and we are grateful to have you, Anna, officially here 5 years. And I really am grateful for Anna. Anna, I'm pretty sure I said that wrong, shame. But she is such a special member of our team. And so thank you, and happy Thanksgiving to you and to Joy. Now, Joy, I love that name. And by the way, I'm a new grandpa again. I haven't seen her yet. She's due in May, but our son and his wife are going to be having their third child. All three are girls, so we are looking for names. We're not. They're going to tell us. But our oldest granddaughter is Jaden. Our second is Juniper. And so since Jager is my son, Jordan is my daughter-in-law, I don't think they're going to be going with Sally or Anna. So it's going to be a J, and my wife and I personally love Joy. That was the long way of getting out there that we're going to have another granddaughter. And if it's Joy, I would love that. But Joy is sharing that her brother died at age 23 years old this year. Oh, I'm so sorry to hear that. Does an extra beat after an exercise test indicate Brugada? He was diagnosed with epilepsy when he was a teenager. Could that be related too? A lot to unpack there. First, so sorry, Joy, about your brother. And I'm assuming that he might have had a stress test. And so one needs to look at all of the evidence. After there's been a death, we try to ask the question, was that death the first warning, the tragic expression, or were there pre-tragedy warning signs? And in this case, it sounds like there was a diagnosis during epilepsy. Now, can epilepsy do sudden death? Yes, it can. And there's an entity called SUDEP, sudden unexplained death in epilepsy. Could epilepsy have been the name, but the real entity been a lethal heart rhythm that caused the person to suddenly faint? And because the heart remained in the dangerously fast rhythm, it did not enable blood oxygen to get perfused to the noggin. And now the brain is electrically ticked off and shows that electrical irritation with a head to toe generalized seizure that looks for all of the world like epilepsy. Yes, that's possible. In fact, many of my long QT patients had been first misdiagnosed as epileptic, some of them treated with anti-epileptic medication. So one has to be very careful in figuring out the diagnosis. But in terms of the specific comment about a skip beat or an extra beat after a stress test, does that indicate Brugada? No, that is a non-specific reaction. It could indicate a lot of things, but it does not indicate necessarily the presence of Brugada. Kim's daughter is asked all the time, is she a heart patient because she has Brugada pattern 1 asymptomatic? I like that, because when am I a patient? when do I have a syndrome, or when do I just have an ECG finding? When do I just have a genetic marker? So this sounds like semantic, but it's actually quite important, I think, because words are powerful and words convey meaning and they can convey risk. And so in my own program, for example, when I have a patient who owns a genetic mutation, I have no doubt about that mutation. I never call them a carrier in any of our diseases, ARVC, CPVT. None of you are carriers. You all possess a genetic marker if your test is positive. So I call you genotype positive. You own the mutation. Now, do you show it? Do you show the phenotype? Are you phenotype positive? And so say you have a long QT mutation, you own it, but I can do every test imaginable electrically and I cannot see it. In that case, I call you genotype positive, phenotype negative. I will often bill as genetic susceptibility, genetic disease susceptibility, but I don't actually call that person long QT syndrome. I don't think they should tell their life insurance that they have long QT syndrome. They have a positive genetic test. Now, when I can make the diagnosis without the genetics, and I can see it from your ECG, your Holter, your stress test, your echo, your MRI, whatever, then whether you've ever had a symptom or not, I call you that syndrome. Now, in the case of somebody who owns a type 1 Brugada ECG pattern, they own a pattern. They own an ECG finding. They do not necessarily have Brugada syndrome. Now, are they a patient? Well, it depends on what I'm going to do with that pattern. If I'm telling them some things to monitor about that pattern, if I'm asking them to come back next year to see if that pattern has changed in any way or we learned more, yeah, then they're a patient, because people don't come back to see heart doctors. Patients come back to see heart doctors. I hope that helps make sense, because I do think it's a very important question. And happy Thanksgiving to you for somebody with LQT1, symptomatic, on a beta blocker, the right one, Nadolol, I like it a lot, on a good dose, 60 milligrams for 30 years. That's a long time, but you're still young, and I'm almost ready to join your club next summer. I need to go to the dentist and afraid about the problems with local anesthesia. Well, first, don't be afraid. There's no reason for fear. I have lots of patients go to their dentist, as they should, get their teeth cleaned, as they should, and I'm scheduled next month. And from my standpoint, the dentist, he or she can do their standard drill, no pun intended. They can do their standard drill without concern. I'm not worried about the local anesthetics. I'm not worried even if the lidocaine contains epinephrine. So that doesn't concern me at all in my long QT patients. So don't be afraid. And basically, never be afraid. You got this. And we're here for you to live and thrive, not fear and fret. So, Lenny from Instagram, is there any research you recommend in the UK? Lots of research seems to be in the United States. Well, it's not the only place where there's research in your heart conditions. These SADS conditions are occurring all over the globe, and we have collaborations and friends everywhere. So in the United Kingdom, there's lots going on, actually. There's some really exciting research with a particular SCN5A variant, for example, E1784K, that's occurring out of London with a dear friend of mine and colleague, Elijah Bear. So yeah, research is happening everywhere. The best thing to do is just look and search and research. We try at the SADS Foundation, as you know, the updates in the SADS e-letter is not constrained by anywhere across the globe. So we put it all out there for you. A reminder of November Family History Month and scrolling. Natalie, when would I say is the highest risk point age for an LQT2 patient? Is it different for males and females? Great question, Natalie. There's what I'm about to say is never an absolute, but in general, we have known for a long time now that there's a switch point, a pivot point in risk based upon the presence or absence of testosterone, the arrival, presence or absence of estrogen and progesterone. So we know with long QT syndrome that before puberty, the prepubertal boys, pound for pound, are at greater risk than the prepubertal girls. Not high versus low, higher versus less. Then after puberty, with the arrival of estrogen, a young woman's risk is greater than a man's risk. So testosterone has some level of QT protection that it provides, whereas estrogen has some level of QT agitation that it confers. So not spooky versus none. No way. I'm not afraid when a girl becomes a woman at all, at least not related to long QT. There may be other worries that take place. I'm not afraid when the child comes out and they're going to be surprised and it's a baby boy. I'm not like, oh no, this is high risk. Not at all. But there is an interesting biology that's taking place where we see that these channels, these ion channels of the heart, are under some level of sex hormone influence. And that's an area of active research all over the world. Actually, there's project going on in the United States with it, in Amsterdam with it, in Rochester, New York, with this very interesting observation that's been known for decades now. So all to say that in an LQT2 person, same with LQT1, that probably the highest risk window of time, if I had to pick which 10 years, and I recognize that as soon as I say it, it's going to be wrong, but which 10 years in LQT2 for a male is probably age 5 to 15. And if it hasn't reared its head by age 15, the risk is very low. Whereas in a girl, their highest risk window of time is probably age 15 to 35. So it's shifted. Now, I don't worry at this as soon as a young girl has her first menstrual cycle, but I do check to see after they have entered menarche, after they've had their cycles. In my own practice, I ask the families to get a new ECG. Let's say I was scheduled to see them 2 years from now. But they started having their cycles. After their third such cycle, even if it's not the 2-year visit yet, I'll have them get an ECG, send it to me so that I can see now with the arrival of estrogen, has the QT significantly shifted compared to what we were tracking as a baby girl, as a toddler girl, as a kindergarten girl, as a 10-year-old girl, and see most of the time, I don't see a dramatic shift. Every once in a while, I do see a shift such that while we might have chosen non-treatment because we thought the risk was super low during those first 10 years, now that the change has occurred and their QT is reflecting the arrival of estrogen in a dramatic way, we might now shift to intentional long QT therapy and introduce beta blocker at that time. And Malgrazada from Poland. Nice. I don't know if we've had somebody join SADS Live from Poland before. So welcome and thanks for joining us. And I think we're going to take this one as the final one, and we'll pick up where we've left off. And this one says an NIH article. Wow, good. I told you guys are amazing. About how the gene that causes loss of function in the potassium channel, that's the root cause of LQT1 and 2, and a possible increase of type 2 diabetes. Is research too early? A great question, great research. And this, remember, somebody asked, is it all United States? Not at all. The leaders of this observation in long QT syndrome are my dear friends from Copenhagen, from Denmark. And it's been known for a while that the LQT1 gene and the LQT2 gene, so for those of you who know, KCNQ1, KCNH2, KCNQ1 builds the Kv7.1 potassium channel. KCNH2 builds the Kv11.1 potassium channel. Besides being in the heart, those potassium channels are also in the beta islet cells of the pancreas. And they are weak, minor influencers, regulators of insulin secretion. And so there is a very mild phenotype of patients with LQT1 and LQT2 can have a weak alteration, almost never detectable clinically in their sugar insulin homeostasis, hyperinsulin, possibility of hyperinsulin hypoglycemia. Almost always it is super weak, like it's nothing. It's scientifically interesting. It's clinically nothing. Now, do I think these mutations could confer risk for type 2 diabetes? My bet is no, I'm not buying that. So do I know exactly that NIH article? No, I'm not sure which one. But what we do know is that these genes express those same ion channels that are resident in other tissues besides the heart, and as mentioned, in the beta islet cells of the pancreas, which are the cells responsible for insulin secretion. And my colleagues in Denmark have shown that there's a very subtle difference in sugar insulin homeostasis in patients with LQT1 and LQT2 compared to normal. So there's a mild beta islet cell pancreas phenotype, but does it practically result in them needing to do something about their sugar management? Not really. At least not yet, and not to my knowledge. And we here at Mayo probably take care of around 1,500 patients with type 1 and type 2 long QT syndrome. So my partner and I just aren't seeing anything from a practical standpoint. Scientifically intriguing, practically doesn't matter a whole lot. So with that, we've come to the top of the hour. We're bringing Live from SADS to a close for SADS Live 171. And may I just say, it is such a privilege to get to be part of your lives. I know many of you, some of you, I've had the privilege to become your genetic heart specialist. But for all of you, we hope you feel that the SADS Foundation is your home and that you find it a place of rest, a place of confidence, a place where you get to experience and be empowered to live and thrive. So we're thankful for you. And as we bring Thanksgiving Day here in the United States in 2 days, I'll first give a shout out to my son, who will turn 27 tomorrow, who 27 years ago tomorrow was born on Thanksgiving Day. So every 7 years, give or take, his birthday falls on Thanksgiving Day. So to Jens, our third son, happy birthday. And to all of you, happy Thanksgiving.